adopt and plan for their families and in an effective way, which also doesn't hamper the economy of the country. We can move to the next one. Then when we look at the literacy rates, and mainly that is by region, and then also by sex and location, of course, Kampala is doing well. It's above the red bar. It's one of those that are doing well, which is mainly in the central. Then when we look at Central 1 and 2, it's also doing well, but our Karamoja is still far away from others. Then when it comes to Bunyoro, it's also not doing well. Teso, it's also not doing well. Now, when you look at other regions that are fairly above the line, I think these are regions that have tried their level best. A lot is still desired, but they are far. Central 1, Central 2, Ankole, and then also with Sichigezi is above the line. Then when it comes to rural urban, the bar has always been up with the urban and very low among the rural. But then the regions, a lot is still desired for Karamoja. A lot is still desired in Busoga region, Bukedia. Surprisingly, the Mount Elgon region is fairly not doing well, but it's fair, closer to the bar. So we are still doing badly. West Nile badly. Toro extremely bad. Bunyoro extremely bad, despite the fact that we have fuel there. But we've not done much in terms of investing in education for the people in Bunyoro region. We can move to the next one. Now, when we look at the school dropout as per sectors, primary and then secondary, you realize that with primary, majority actually end at primary level. Secondary, few transit. Now, unlike like Elgon performed so well, or it does perform so well when it comes to enrollment and retention in primary up to primary 7, but when it comes to retention and completion at O level, then they drop, they come down. The rest of the statistics are still the same for most of those particular regions, and we see that a lot is still desired. Even just pushing our little ones up to O level, it's a problem. With the Education Plus initiative that we initiated and launched recently, we did realize that 25% of our girls do not complete O level. But even those that manage to complete out of the 25, it's majority complete from private schools, and that is 66% of those 25 complete from private schools. So it means even though we have universal secondary school education, it cannot promote and it cannot ably support these girls to complete school. So it means majority drop out of school at the end of it all. So when we are looking at the epidemic, we are ideally looking at a bigger cohort of those that are not in school, unlike those that are in school. That's why we launched Education Plus to push government and other stakeholders to say, let's keep this child in school. When you keep them in school, you actually reduce HIV, reduce teenage pregnancy, gender-based violence, early marriages. You hit 5 birds with one stone, and you're in position to achieve more than when they are out of school. We can move to the next presentation. Then when we, please, to the next one. I think I've explained that one. Then when we look at child marriage in relation to dropping out of school, it still codes the same. Those with no education, they are more married. Of course, it's more of the women of 20 to 24. And before they reach 18 years of age, they've already given birth. Then those that have accessed primary education, the purple coda is for the women, blue for men. Those that have reached primary level, again, many of them have actually given birth by the age of 18, by 20 to 24. Majority have given birth before even 15 years of age. Secondary school, that is how they are. So that one clearly shows us that once we push to a particular level, then we are in a better position to reduce HIV, teenage pregnancy, early marriages, and then also sexual gender-based violence, but also reduce poverty levels within this particular age group, which have registered the highest infections in the country, and also higher teenage pregnancy rates. We can move to the next one. Then when we look at issues to do, next PowerPoint presentation, please. When we look at issues to do where we do find is out of school, I've used Karamoja picture because they have the worst impact when it comes to dropping out of school. They are more affected than any other region. But that is where we find our children. They're either on streets, they're in salons and sauna, they're house helpers or house managers, which we call maids, shamba boys, market vendors, but the list is endless. But these are the areas we'll find these girls. And we do not know what exactly happens to these young girls. Hotel cleaners, they suffer a lot. Even when they are laying people's beds, they are being sexually abused. Sometimes they go into those rooms and the residents are not ready to leave them go as they come in. But this is information that is not, that rarely comes out because private sector is private sector. Sexual exploitation and abuse, it's not an area private sector will focus and concentrate much more on, but it's something that happens when it comes to in saunas. We know a lot happens, and it's usually these young girls that are dropped out of school that are actually utilized for those kinds of jobs. Yet our interventions tapping into those categories of people are actually minimal. We are aware the resources are minimal, but I think it's time for us to creatively think, most especially how we critically engage with the private sector. I know this is a sector that Ministry of Gender is in control of, and you have the right to call to act to this private sector institute, because if we start looking out for our 15 to 24, and we say, where are they? If they are not in school, so where are they found? Private sector is our hub. And more than before, we really, really need to work with private sector. We had a chance to have a training for those that are learned, like the corporate bankers. And we were shocked, I won't mention the bank, but we were shocked to appreciate and understand the level at which sexual interactions happen in banks without protective measures. And actually, in that particular bank, all that they wanted from us, they told us simply, give us PrEP if you can, because that is what we want. They never wanted even condoms. But the young girls told us, for us in the bank, we are more or less like sex workers, which is not right, but that is how they were feeling. First of all, the bank doesn't give them enough time to interact with the outsiders. They do have, but once in a while, like on a Sunday. They go in early, leave very late. Yet at the same time, they are young, they are growing. We've all passed through that stage where you feel, I'm ready for anything. I've developed, I've matured, and I think I'm now ready. So when you look at the average age of bankers, it's between 22 to 29 years of age. So they are still among the 24 cohort that we are looking out for. But we rarely have interventions for bankers. It's only good banks that will be innovative to say, on World AIDS Day, can we do this for our bankers? But a lot goes on in such private places. Hotels, it is worse. Yet these are areas that we no longer target. And we keep saying we don't have financial resources. They are not enough. But I think we creatively need to see how we reach out to these particular categories. We can move to the next one. I think the next one is for us to imagine if those in school can access sexuality education or life skills, well, those out of school can't access. Do we think we'll reduce new infections? The answer is no. Poverty level, no. Child marriage, no. Teenage pregnancy, no. Mental health issues will keep rising. Violence, defilement, suicidal tendencies, drug abuse and substance abuse, then trauma. So even if we concentrate more on the in-school and we exclude the out-of-school, we are more or less wasting our time, since we already know that within school, majority drop out, because that is how our education system is. Due to several challenges, the young ones keep dropping out. So we need to work in tandem in terms of targeting both, although our major concentration should be on pushing them to go to school, pushing government to ensure that we make school available for everybody. That has been done for UPE and we appreciate. For UCE, it's not the same. A lot is still desired for UCE. We can move to the last one. I think that's the closer to the last one. Now, what perturbs us most now is what we call ending inequalities to end AIDS. What is ideally failing our young girls and also failing us to reduce teenage pregnancies, early marriages, HIV, and other particular health-related hazards is that term inequalities. As long as we are not equal in distributing resources, not equal in approaching particular groups, we approach others we don't, we'll continue registering new infections, and that will not help us to end AIDS by 2030. Because if we are to end AIDS, then we must have everybody put on ARVs, and those that have enrolled, they keep in, suppress their viral load, then we would know that we are on the verge of ending AIDS. Not HIV, I keep re-echoing, not HIV. But globally, we have 38 million people that are living with HIV. It's only 28 million that are on treatment. So we still have a big gap of 10 million that we need to put on treatment. Even locally here in Uganda, if we say we have 1.4 million that are living with HIV and it's 1.2 with some denominations that are on treatment, this is a gap. So it means we won't be in position to end AIDS, even when we do not suppress the viral load. So the only way we can manage that is to make sure that we cut across everybody. As long as you're an animal called human being, you're important to us in the HIV response. For us, we don't believe in give this cohort, leave this cohort. No, everybody is part of us. Whether you're a young girl who is disabled, you're a young girl who is a sex worker, a young girl who is a transgender, a boy who is even an MSM. That is a language people don't want to hear about in Uganda anymore. But for us, that category has to be reached out, because it's important and critical to cut across everybody so that we do not register new infections and we do not look out for new ones we are putting on treatment, but we simply suppress and we say we have ticked the goal of ending AIDS by 2030. As now we concentrate on science to get the cure for HIV, and I think we are closer. We are closer to getting the cure. If you look at the journey from 12, actually the beginning there were around 18 tablets, you go to 12, you keep going, now it is 1 for the first line treatment, and soon the injection will be coming, then close will be there to get the cure. So we know, we are confident that with time we'll get the cure, but we don't have it now. So we are still concentrating on ending AIDS. And we should be in position to end inequalities, and that is our global strategy, accompanied with areas that were not part of the other old one. We still run the 95-95 enroll have 95, you can go back to the upper 95, access HIV testing services, enroll them on treatment, suppress the viral load. But then we have the 10-10, which speaks to 10% of the countries reducing stigma and discrimination among people living with and affected with HIV. Then the laws, having 10% of the countries with favorable laws. 110 looks at the country level, 110 looks at the individual, and also another one looks at the individual perspective, reducing gender-based violence among at least the individuals that are affected and those that are living with HIV. Then we have others that are on 30, 60, 90. 30, 60, 80, 30. Make sure that the programs are delivered by the communities themselves. 60, community should be in the lead. Then 60, financing should, 30, financing should go to the communities. 60, communities should be it should be the ones implementing. 80, it should be the communities in the lead. Now in this particular case, Commissioner, we have no young person from here who has dropped out of school. It is our call that for any other engagement, however high level it is, we invite at least one that has dropped out of school to give us his or her experience. That is what we refer to when we say 30, 60. Let them lead because they know it better. If I'm a mother and I lost a child while giving birth, I know my situation better than any mother that has never lost a child. So I can tell you how I went through it and how I managed. It's the same situation we had for COVID-19. When people never learned from those that had suffered from COVID-19, we were running to hospitals and we registered tremendous deaths. Ambulances had become ambulances everywhere. But when those that had healed from COVID-19 started giving us testimonies and saying, for me, I used ginger, I used lemon, I used this, I steamed, people adopted that, ran out of hospitals, and lives were saved. So it's the same anchor we use in UNAIDS. People living with HIV lead the way. They tell us, if you don't take ARVs, you will not know the impact of ARVs. But the one that takes them will tell you, this is what happens when I don't take. If I don't eat, then these are the repercussions. So please invite the young ones to lead us and tell us, mainly those that have dropped out of school, what it feels. So how best can we plan for them? So I think we are aware with sexuality education, there are many programs going on for in school, but out of school I'm not so certain. I know Dreams tries to touch a bit, to focus on those that are out of school. It does, most of them, actually the bigger number, though it tries its level best to take them back from another version. Then Second Chance to Education. There are programs, but they are not many. So you see even here, I could not mention many of them. So I think a lot is still desired, and a lot still needs to be done. While for in-school, the programs are quite many. Though it's also not much, a lot is still desired. I think we move to the last one. I just want to thank you for listening to me.
I really think that your clapping is enough for Sarah. It's one thing to have a job and do the job. It's another being passionate about the job. You could see she was really speaking from the heart, not just speaking, and giving us issues that I think some of you should be annoyed with. That we think our children are going to the bank to work and we look at them very smartly, yet things are happening behind there. We see them going to hotels and we believe they are simply working, yet a lot is going on inside there. What about your workplace? What about your workplace? Reverend, what about in the church? Of course, I'm not supposed to say these things about the church, but we know that our society has been highly infested with vices. And we cannot keep quiet about them. It is Dr. Martin Luther King Jr. who said that society begins to wither, rot, and die away the moment we keep quiet about things that matter. You could be dying in silence. I hope I'm safe. Not to mention that maybe some things are happening in Parliament also. I hope I'm protected. I've seen marriages that have failed. But I don't want to talk about that because I'm a public servant. You may call me under Parker or under guys, and you really discipline me. So I've not said anything. Oh, Parliament is sorry. The data should make us annoyed. Fifth in the new HIV infections. 52,000 annual infection rates in Uganda. 38 million people living with HIV/AIDS. 1.4 are Ugandans. And I was looking at statistics the other day that showed me that in 2016, 1,880,000 children entered P1 or enrolled in P1. At the end of 7 years, that is in 2022, only 834,000 sat P7. We need to ask ourselves, where did the over 1 million go? Where are they? So Naku, when she talks about majority of our children are not in school, they are out there. What services are reaching them? Therefore, in finalizing the out-of-school sexuality education guidelines, we need everybody's support. We are at the tail end of this activity, and I realized, Mr. Pierce, I realized that we need these guidelines today, if not yesterday. A Chilean poet called Gabriela Mestro said, "We have committed many sins, but the worst sin is to neglect our children. Many things can wait, but our children cannot." We need to do everything possible to manage the spread of HIV/AIDS everywhere, apart from the holy grounds in the Parliament where things are okay. So I want you to join me in thanking Naku once again for creating awareness. I'm now going to turn to the difficult part. We want to see some reflections on what has been presented. And I want to invite in no particular order, the following to take up the seats so that we can have a conversation about what Sarah Naku has presented, about what the Permanent Secretary, Minister of Gender, has talked about what Commissioner Equity and Rights has talked about, and everything that is running in your brain. We want to interrogate and see how do we manage. The PS said it's a Herculean task, but he added that it's not insurmountable. It is surmountable. It can be done. May you also allow me to recognize OHT Dr. Joyce Abaliwano, Minister in the Busoga Kingdom. Thank you, Dr. Joyce, for coming. May I invite Mr. Magara Henry, CDAHF. May I invite my big brother, Dr. Musoba Nelson, the Director General, Uganda AIDS Commission. Please clap, please clap, clap. May I invite Ms. Chaptoris Juliet from Ministry of Health. May I invite Haji Yidi Mayanja from Ministry of Gender, Labor and Social Development. May I invite back Ms. Sarah Naku, and may I also invite Ms. Nakato Kirara, Youth Representative, to come and take up the seats, and we start our conversation. Can I have my people with the machines to, Gorowa, can you help me give them the microphones? As you realize, the problem is so big that the space is not enough for all of us. But we are trying to squeeze ourselves to ensure that we can do it together. Because we have seen that this problem requires a multi-sectoral approach. Multi-sectoral approach, and we need engagement of everybody. I'll start in no particular order. Let me start with Mr. Magara Henry. Mr. Magara Henry has already talked to us. He is the country program director for AHF, Uganda Cares, and Public Health Profession. He has more than 15 years experience in leading health programs. He has been instrumental in scaling up HIV services in Uganda to the current 64 health facilities spread across 28 districts in the country. Henry is an advocate for preventive health, health financing, sexuality education, patent waiver, and local capacity vaccine production, among others. He holds a bachelor's degree in science, a master's degree in business administration, and another master's degree in public health. Henry attended a 6-month secondment training in Brussels on Africa EU engagement and grant making. Henry served as chairperson of the program committee of the Uganda Country Coordinating Mechanism of the Global Fund. He currently serves as the vice board chairperson of UNESCO. Henry, with all those so many things that you are, can you tell us what initiatives has the AIDS Healthcare Foundation undertaken to reach out of school adolescents and young people with HIV prevention programs?
Thank you so much, our moderator, Mr. Mondo. There are quite a number of them, but I would say that advocacy has been one of the initiatives. And the forum for today testifies the fact that it's such engagement that people come to know about the life skills that our young people need, to keep themselves safe from HIV infection and also making right decisions. So we have championed policies, guidelines, ensuring that they come in the public arena and they are discussed. Public awareness has been one of them, and as you have heard, the experience from the bank, you may find that, our bankers don't know much about, HIV and AIDS. So this is an area that I've championed as an organization to ensure that there is awareness about, sexuality of everybody, the unmet needs, and we have done a lot of media. We have engaged young people in webinars to ensure that they know about what does it mean to be a male, a female, and how do they, make right decision relatedly. As an organization, we have tried to involve the young people that are affected. And yes, I confirm with Madam Naku that you need to involve those that are affected. So as HF, we have come out with an awareness campaign involving the young people. It's called the Girls Act. And here in our selected, supported facilities, we get what we call champions, take them through the issues to do with sexuality, how can they protect themselves, how can they make decisions. So these champions have been able to reach out to other girls in the community to talk about the unmet need about life skills and health education. And we have built their capacity to ensure that they can engage with the public. At one time, they engaged their committee on Parliament for health, gender, and they are articulating what their needs are. So that's a capacity that we have been able to build. But they have also engaged communities, leaders, cultural leaders at district level to discuss issues to do, for example, menstrual hygiene, health, teenage pregnancy, and those dialogues have been very instrumental in providing solutions. Youth spaces are very important for the young people to discuss, their issues. And as an organization, I've tried to ensure that, youth places are created before you close me out. There's one that we set up in Masaka, and the former Minister for Youth, Student Affairs was able to come and, open it and hear the young people discuss issues affecting their sexuality. And then we have also worked with other organizations also to have, what we call youth drop centers. So those are some of those that I can mention.
Henry, there's a tendency of people thinking menstrual hygiene management is about giving pads. You see people, civil societies, they go out there, they say, we are in the business of menstrual hygiene management. We gave out pads to 3,000 girls. Is that the strategy you also use? And if so, you think that's it?
It has to do with understanding, the growth of a person, a young person, especially young people. Understanding, the growth stages that they go through, and then how they can, manage it, and looking at who should also be able to support. So we invite experts in these areas, and they are able to take them through.
All right, thank you very much. I want to go to my big brother. The Director General, Uganda AIDS Commission needs no special introduction. Dr. Nelson Musova has worked at various levels in health systems of Uganda for the last 18 years. A big component of Nelson's experience has been in Uganda, where the health sector has been implementing reforms over the last 20 years. Important among these is a sector-wide approach for health development and donor coordination, public-private partnership for health, and participation in the development of health sector policies and plans. As a senior health planner at the Ministry of Health, Nelson was responsible for coordination of the Global Fund for AIDS, TB, and malaria, Uganda office between 2007-2012. It is a big CV, which I don't want to go into. But Nelson is a household name in Uganda, and he has been at the helm of Uganda AIDS Commission for some time. Dr. Nelson, I want to know from you, how can Uganda AIDS Commission support the involvement of community-based organizations and local stakeholders in addressing the challenges faced by out-of-school youth in terms of HIV prevention?
Thank you, for that kind introduction, but also for the opportunity to engage in this very well coordinated event. I want to congratulate the ministry for successfully convening us, because to have 3 chairs of parliamentary committees in your event is no mean achievement. So, in addition to the other stakeholders who are in here, so congratulations for this successful convening. Communities are key if we are to end AIDS as a public health threat by 2030. And thank you, Sarah, for clarifying the definition of what is to end AIDS, because I get that question all the time, that we have no vaccine, we have no cure, but you're talking of ending AIDS, and you spoke that very well, because the definition of ending AIDS means that we should have no death as a result of HIV by 2030. We should have 0 stigma and discrimination, and we should have 0 new infections. But the people living with HIV will not transmit the virus to other people, so we will have, arrested where it is. And where we've reached, and the examples that have been cited, communities are supposed to be in the forefront if we are to win this war. She's given you the examples of banks. I was sharing with the chair of the HIV committee about this problem, and I would like to thank, when I listened to the commissioner testify about his personal life. When we talk numbers, it seems a distant thing, 1.4 million. You're thinking, they are out there. But when you listen to his testimony, and when each of us reflect, look at your family, look at your siblings, look at your parents, look at your immediate relatives, and I want you to pin, you'll find that either if you've not lost a person directly, you have somebody living with HIV. Amongst those, at least for me, when I look around, I see them, and it becomes a picture that, this problem is not just in the past, but it is here with us. So how do we deal with it? Yes, on the science front, on the public health front, we are doing well. The Ministry of Health has all these interventions. We are working with partners, and we are trying to reach everyone, encouraging people to go and test. But you can see that the remaining challenging components of ensuring that we achieve the last mile are, one, around behavior, and that is why we have to look for a solution. I was whispering to the representative of the permanent secretary from the Ministry of Gender and saying, how many anthropologists do you have in the ministry? We need behavioral change experts. We need people to find what motivates this high-risk behavior. Of course, there are other predisposing factors, issues of wealth distribution, issues of stigma and discrimination. But some of the stigma and discrimination issues are internal, as you know. So what motivates an individual to step forward, to go and take a test, to take a public testimony like we had? Because very few of our colleagues, for instance, are willing to come forward and testify, and again, because there are consequences. So we can only do that if communities are in the forefront, if they take leadership, if we explain these things to them. And we generated consensus with the chair of the HIV committee that we have to go out and make more noise, make more useful noise, be out there. Let us say that this danger is real, it is next to us, and it's up to every individual to take a personal decision and, ensure that either you know your status, you know the status of your neighbor, of your loved one, and let them, because it's, and Commissioner Mondo, you did very well when, after mentioning the issue of the example of the banks, it's everywhere. It's in our homes, between heads of households and the maids. It's in at the workplace. I actually told her that the second next thing after eating food that is popular out there happening is sex. That's what I told her, and that's the reality. So that's what we have to confront and deal with. And the priest is smiling, but it's the reality that we have to deal with that is out there, and look for what are the remedies that we need to check. And I think...
I understand sometimes people skip lunch and they go for lunch. You understand what I'm talking about?
Yeah, so that's the thing that we have to confront and say, this is before us. What is it that we need to do to ensure that as we undertake, all these people are safe, that every time you go out and you're contemplating a sexual encounter, know that there are dangers. There are real dangers and risks. And across public health, not just HIV. The young ones should know that a young woman who has multiple sexual encounters is predisposed to HPV and therefore at risk of developing cancer of the cervix later on. That you could have other sexually transmitted infections. That there are so many things, mentally, your mental health is getting affected. That men need to be known, to be taught that your actualization, your self-worth as a man is not from the number of women you sleep with. That there are other ways, you can prove useful to a community and to yourself, because sometimes it's a deeper problem. We shouldn't just blame the individual man who is all over the place. They are responding to a deeper issue that resulted from the surroundings, where they were brought up, what they grow watching, and they are trying to express that differently. So behavior change is key, and the communities will have to be at the forefront of dealing with that. Of course, we'll need resources, and I'm glad that the legislators are here, because for us to champion that, I was again telling her that care and treatment, we've done well, but when you look at the resources, the way we've allocated them, we've not had sufficient resources for prevention, for behavior change. We need to attack that with equal measure. Invest in communities to ensure that that part of the intervention is done.
Director General, before you give away the microphone, you are talking about community engagement, and we are talking about going into the out of school. What challenges should we prepare for in trying to target the out of school youth with HIV interventions, with issues about their sexuality, with all these packages we are talking about? What are some, from your long experience, the challenges we are likely to face? By the way, together, because we are going to go into the communities with you.
Yes, that's true. So that's an important thing to put into consideration, that as you go out to talk to the youth who are out of school, the last thing on their minds is about being safe from sex. Their most immediate need is likely to be, do I have food on the table? Do I have this that I need? So your message is not likely to be a priority. So that is going to be a key challenge. And that is where we need to move in as a multi-sectoral response. That if we have yourselves, if we have the education sector, if we have the health sector, then we say, these are the things we are doing to ensure that, we are cushioning households towards poverty. We are ensuring that the school retention rates are higher, but their most immediate needs are number one. Two, what we've seen from the studies is that, and Ms. Saranaku demonstrated part of it, is the awareness and the knowledge about HIV is unbelievably low and worsening, because the most recent study showed actually that the number of sexual partners was rising instead of reducing, especially amongst the female partners. So comprehensive knowledge is low and even declining. in the hierarchy of needs, their need to have knowledge and protect themselves about HIV falls very low on the ratings. Their needs about, survival, putting the daily meal on the table, issues around stigma and discrimination is the other. How easily they are willing to come out and take an HIV test because of the misconceptions, because they fear they will be discriminated. So those are key, and therefore going into it as a multi-sectoral group with yourselves who are experts, in communities and interventions, with the health sector, with the education sector, with the civil society, colleagues and others will be important for us to be able to deal with this.
Now, Clara, Nakato Maria Clara, we want to listen to the voice of a young person. The old people have spoken. We want to listen from you because they are saying HIV is there around that age group. Now tell us, as a youth advocate, what are your observations regarding the challenges faced by the out-of-school youth and adolescents in our communities where you stay, where you work, or where you go with your interventions?
Good morning, everyone. Thank you, the moderator. Allow me to first and foremost recognize the government of Uganda and all the other intergovernment agencies for the amazing work that we are doing to protect the right to health for the young people, but also to ensure that the youth of Uganda have a brighter and a more supportive life. To respond to the question, I know most of my colleagues and really what Dr. Nelson highlighted around the challenges. I'll still echo on the issue of the gap to access to comprehensive HIV and also sexual reproductive health information for the young people. So as a country, we need to still pay attention on how do we convey information to the young people. And even as we highlight that is the issue, there is an information gap, the responsiveness of the youth or even the overall young people to appreciate this information, which is of course a fact that many do not know, but even those who know assume that information is not right, it's not just sufficient enough, and it goes back to how we convey information. A number of times we've had the educators being intentional on imposing abstain. So how do we ensure that as you're telling someone to abstain, you're intentional on conveying a message that speaks to the holistic needs of this person? And on that note, I would love to also note that looking broadly on our environment and the context in which we work in as Uganda, we all know that morality suppresses the realities of what young people face. So in one way or the other, even if I come and say, I am 13 years old and I'm having sex, or you're immoral. So there is a lot of that judgment. And I think then that brings us to the point of how the social construction and the cultural aspect, the opinions and the thoughts that are derived towards HIV as a concept, but also the overall SRIH issues. So on that note, I would love to highly echo that the access to information to young people should be driven by the people who they strongly relate to. And I think some of the models that have really worked for us are the peer-to-peer approaches. We have the YAPS model. AHF one day launched the Girls Chisoboka, and we saw very, very many young people leading information, giving it in a more edutainment way, in our swag, So again, for the government of Uganda, especially the Ministry of Gender, you need to be intentional on recognizing the role of young people in conveying that information. And again, for me speaking as a young woman living with HIV, and also as an advocate, it's easy for me to then relate and speak to young people in a mode that I am not telling you, please abstain this and this, but I'm conveying it in a way for you to know that, well, HIV could look swag. Many people like it swaggerific. There is treatment, there is everything. But again, you need to understand that living a daily life on a pill is not easy. So would you want to go to that side? Or then you have to choose to stay safer. The other thing I would love us to still pay attention to is how can we be intentional on addressing those biasness? And I think it comes from the people that we trust, the parents, the cultural leaders in all this. And I would love to still emphasize that we need to do a lot of work to engage the cultural leaders, the religious leaders, to allow them to find a place within their heart where they can provide information to the young people to listen to them. I'll end my point by noting that the conversation of reducing SRH challenges or even new HIV infections among young people is a responsibility for everyone. And we need to step up and ensure that at all levels, how are we well coordinated? As most of the members have highlighted here, the private sector has to be brought on board because this is where the money is. But we know people are eager to follow money and forget about their health. Yet the truth is, how can you make money when you're not healthy? Well, you could die and your money, you will have not enjoyed your money. So we need to ensure that all these partners are brought on board. And then for me to strongly emphasize, we need to recognize communities. Work with communities, work with community-based organizations or the informal groups. I know sometimes it's hard because we assume that for us we will just go one off, give a shoot and then leave. But again, these people know the communities. You will not go there dressed in your suits smartly and you feel like people will listen to you. If you're going to Kejong, you need to dress up like us. If I go to my home district in Tororo, then I need to assume that, well, there is a way I have to present myself and the language. So we need to learn from the models that have worked for communities and us not to forget the best practices. I think in the early 2000s, if you look at the way the PRC model worked, everyone was on their toes to ensure that information on HIV is appreciated by the communities, by the young people. And many of us were eager for those healthy Tuesdays or even the Friday school days where you could do the music, dance, and drama. You could take lead and actively engage. So again, on that note, we need to go back to that best lesson on how can we actively engage young people and ensure that they are on the lead, they are driving it, they are teaching each other, they are facilitating each other. It is quite expensive because then it's going to really push us to invest funds. So again, we need to put the monies where the monies work. And I think the evidence has shown young people should be key in leading. Thank you.
Oh, thank you, Kirara. Kirara, no, please clap for Kirara if you must. Oh, thank you. Clara, you talk about inclusiveness. How inclusive can we be? Already we have been challenged by Sarah that we should have brought somebody here to give a testimony. Tell us, to what extent can we be as inclusive as possible while dealing with the out of school?
So allow me to first and foremost note that when we say inclusion, many of us jump to that bargain, oh, we are inclusive because we've provided the bare minimum standards. Inclusion has to be intentional and action-oriented. The young people of Uganda are diverse and highly dynamic, and so are their needs. So the one-shoe narrative does not fit all. So on that note, we need to be intentional on holistic needs of young people living with HIV, but also entailing that beyond their HIV status, there are other psychosocial needs or even other psychological needs. The same applies to young people with disability. Beyond addressing the needs around their disability, we have to be intentional on highlighting concepts of where are there other needs. So again, as a country, we need to step away from the bare minimum on feeling like, oh, a person has a disability, please provide an accommodative mechanism. But then you're not addressing the sexuality part because this person will tell you, I would love to have sex. How are we addressing that? You know? So we need to still ensure that all the encompasses of someone's lives are held onto on board. I'm happy to note that our government is stepping up to ensure that the inclusion of all persons is brought on board, but still we have a big challenge and we need to deal with it. We all know how discrimination, exclusion of people is institutionalized in the laws and policies that we have. So Uganda, with all the beautiful policies that we have, in one way or the other, we then contradict ourselves. If you look at the HIV Control and Prevention Act, it's very, very beautiful. But in there, it criminalizes. It criminalizes HIV. It criminalizes the intent to transmit HIV, which of course you cannot define. How can we define that, oh, I was intending to infect someone? Even with the current narrative that is happening with the Anti-Homosexuality Act, which of course many of us greatly welcome. But again, we know the implication of that on how it will allow people not to enjoy their overall right to health, or even to enjoy the humanness to be themselves. So we need to pay attention every time we are reflecting on these laws and on these laws that we highlight. What is the implication on the fulfillment of people's right to health? So for me, I'll conclude on that by highlighting that we need to pay attention to the rights to health. And I think as Uganda, we are still lagging on that. But I'm hopeful we can do better in the future.
Right. And the youth are saying there is nothing for us without us. Inclusion, inclusion, inclusion. Now let me go to my sister, Juliet Cheptoris, Program Officer HIV Prevention among adolescent girls and young women at Ministry of Health, 4-point person, health sector, gender-based violence and violence against children, response at Ministry of Health for over 6 years. Juliet, tell us what measures are being taken to address the unique health needs of out-of-school youth in Uganda, particularly in the context of HIV prevention and sexual health. What are those unique interventions you are undertaking? You will also comment on how the Ministry of Health is ensuring the availability of accessible and youth-friendly health services for out-of-school youth in the country. In my interaction with some of your people and the chairperson of the Health Committee in Parliament, one of the issues that has come out is that space for even other things is not enough. So talking about youth-friendly corners is a far cry. And you say also that it's very expensive to talk about youth-friendly services. But we're also saying that the youth are not cheap people. They are the future of our countries. What's your argument?
All protocol observed. Ladies and gentlemen, thank you very much for those very many questions. I hope I remember all of them. And thank you. And I'm privileged to have spoken after the young person. I must say that I'm also a young person at heart. I bring you greetings from the Ministry of Health, especially from the Program Manager, AIDS Control Program, who should have been here, but nevertheless, he sent his greetings, and I'm happy to represent the program. I must say that as the Ministry of Health, like you have rightly said, the position of the adolescents and young people is very critical, and the Ministry of Health has set up a special division called the Adolescent Health Division, and that tells us that adolescents and young people are a priority in the Ministry of Health, and we have a number of guiding policies that guide service provision and even based on evidence. And specifically speaking to the last question about what interventions have been provided in addressing I want to say that, just for information, the programs for adolescents and young people are not in isolation. So the AIDS control program has very well stipulated, consolidated guidelines which provide guidance on how services should be provided, HIV prevention, care and treatment services. So specifically speaking to the uniqueness of HIV prevention services for adolescents and young people. The Ministry of Health has specific programs. Before I talk about the targeted programs, I first want to talk about the generic programs that target adolescents and young people. So we have a number of these programs within the Ministry of Health in the AIDS control program, and they include targeted biomedical interventions. Sarah talked about providing PrEP. That is a very good innovation that Ministry of Health recently launched, and we have guidelines to ensure that adolescents and young people who are at risk of HIV infection can be prevented from getting infected with HIV. And also specifically talk about tailored programs to support adolescents and young people, especially male adolescents, to access voluntary male circumcision, such that they can increase the chances of not being infected with HIV. And also ensuring that we have the last mile distribution of condoms to young people at community level, into the brothels, into the bars, in the private sector, ensuring that they're distributed into the smallest pharmacy at community level, such that somebody, a young person, can walk in and access a condom, so that they can be prevented from HIV. But needless to say that through health education also, we have a number of campaigns which have been running, specifically addressing young people. I think you have seen the old Oblamo campaign, but also we have a recent campaign that is targeting young people to ensure that they get enough information such that they are able to make informed decisions. And all this is based on evidence. So we have in the campaign tailored messages for adolescent girls and young women, tailored messages for men, because recently data showed us that actually it's not just the adolescent girls and young women, but also the men have a higher prevalence of HIV, and yet they're the ones who come to the girls themselves. So targeted HIV prevention messages have been aired, and also ensuring that we build capacity of our health service force to provide these services. So now let me talk about targeted HIV prevention and care and treatment interventions for young people. I'll start with the side of care and treatment. She talked about YAPS. The YAPS program, YAPS is an abbreviation. It is youth, adolescents, peer support. Because we realized that when Sarah talked about some of the statistics, just to add that we realized that viral suppression among young people is actually much lower compared to the adults. So this program was designed to ensure that we use the peer-led approach that you talked about very well to reach young people themselves. And so this program, the YAPS program, has been decentralized up to service delivery level at the health facility. And the young people are actually picked from the community. So they also act as a linkage between facility and community. They do referrals. They conduct HIV testing for their fellow young people. So through that program, we've learned that the power of using young people themselves is very supportive in ensuring that we realize positive health outcomes for adolescents who are living with HIV. Then for the side of HIV prevention, I will talk about, Sarah talked about it a little bit, that having realized that adolescent girls and young women, like you've heard, contribute the biggest number of HIV infections in the country. We have had to develop targeted programs for adolescent girls and young women. I just wanted to add a little statistics to what Sarah had talked about, to say that recently, last year, we did a population size estimates for adolescent girls and young women, and realized that right now we have about 6.2 million vulnerable adolescent girls and young women, just from that population size estimate. And then there are about 73 districts which have a very high burden of HIV infection, where these vulnerable adolescent girls and young women are found. But also, the comprehensive intervention programs that we have only target about 44 districts. But also within these 44 districts, cumulatively compared to the number that we have to reach, we are only at about 11% of the girls who should be reached. So, and we know from the statistics that Sarah shared that most of these girls are actually out of school. And the vulnerabilities are really diverse. And also, we realize that we have an increasing number of young, vulnerable adolescent girls and young women who are below 17, who are more vulnerable to HIV infection because they're engaged in transactional sex. Before you cut me off, Chair, thank you very much, because you asked me a number of questions, okay? Thank you very much. So as we continue in this discussion, I want us to bear that population, take that cognizant in that as we continue with our discussion. Also, for this targeted population, for the adolescent girls and young women who are pregnant, who are breastfeeding, who come to the facility, we formed what we call group antenatal care groups, which are based at facility. Now we are asking that in this dialogue, as we discuss, this evidence is really good. Can we have this at community level? And then, was there another question?
You will be coming to that later. You specifically, as you give the mic to your neighbor, when I come back to you, you talk about the issue of youth-friendly services. What do you think, what's your take about youth-friendly corners to enable the young people access? Use my colleague, Haji Mubarak. He has just returned from Mecca, so I make it a point to follow him, Haji. I might get the blessings that he came with from the Hijjah. Haji Mubarak is a public specialist. He holds a postgraduate diploma in gender and local economic development, holds a diploma in project planning and management, a bachelor's of adult and community education, and is a principal gender officer at the Ministry of Gender. He's a person for many interventions at the ministry. And so I want to address you in that right. Can I get from you, we have seen that HIV and AIDS statistics are worrying for girls and women in Uganda. What specific interventions can we adopt to make our prevention and response more gender responsive?
Yeah, thank you, moderator, for that kind introduction, and good morning, the audience. I think I want to tie this to the presentation we had here by Sarah in the morning, but also what the young person has just spoken to us. The issues of being intentional, I think it speaks volumes. On Sunday, New Vision, I think the country was awash on how it presented the Busoga sub-region. the 34% of adolescent young girls who are defiled, and the reason which was actually given in that picture, they put there a chapati. And the statement was that here, teenage girls are being lured into unprotected sex in exchange for chapati. That costs 500, and that is not all. Of course, for us as a machinery for social development, this speaks volumes in terms, first of all, using logic and reason. Do we need to redefine the interventions that we are doing in the communities? Sarah spoke about issues of knowledge gap. She speaks about poverty as very key, one of the triggers. So, do we need to reevaluate and re-examine the drivers, the triggers, the contributing factors that you know, the high percentages that she presented in terms of prevalence of sexual violence in the country? And if that is so, if we are assessing ourselves, are the interventions working or they are not working? When the country was infested here with the global virus of COVID-19, in the 2 years that we were in this problem, statistics data under Uganda National Household Survey of 2022, it indicated that over 400 girls were impregnated in this country. And the question was, because it also gave who impregnated these girls. Then what was very sad was that the people who were actually impregnating these girls were the biological fathers, for instance, the close relatives, the uncles. Now, back to what the moderator asked, what could be now the robust intervention that we can design as a social development sector to ensure that we are addressing the rise of infections in adolescent or in the young people in Uganda? I think for me, the role may not be for Ministry of Gender, Labor and Social Development, but a multi-stakeholders approach, a holistic approach that each of us has responsibility to do what you are supposed to do. And of course, during Sarah's presentation and the young person here, they were employing cultural leaders, our religious leaders, who is sleeping on the job. That is the question that we must, as we are designing the interventions out there, who is sleeping on the job? Because so far, what we have piloted under the programming of the ministry, for example, all the empowerment programs of reducing poverty, reducing inequalities, that gender gap that we are saying, how many, for instance, women, because we are aware that if you empower the women, if women have resources, then you will see reduction in sexual violence because the women may be there to support the young girls because they have resources. On account of that, the fathers, they are not responsible. And that statistics has also been, that's why local governments today, they are struggling to come up with ordinances to regulate alcohol use. Why? They think that is one of the underlying causes of some of these violence in our communities. We have paraded a number of programs targeting young people. For instance, the Economic Empowerment Program, Uganda Youth Livelihood Program. The question is, why is young people not coming out where they are? What is the problem? When I was working in the local government, you flooded out 15 million shillings to a group of young people. 5, 6 of them, 8 of them, after a period of 1 year of evaluation, they have nothing. And we realized actually that that money was causing internally for young people to migrate from their places to new places. Then, of course, we need to go back on the drawing board. What is the problem? So I think the gender inequalities the inequalities that Sarah has spoken to today, we need to be intentional to look at what are those challenges that are continuing, especially if we are targeting the other worst gender in terms of uptake of the program. Is it for the young person where she was defining, is it youth-friendly services that we are failing to provide? Are we failing to be intentional in terms of providing information? Then it is, I think we can now work together. But currently, I think we are flagged out the issues of social norm. Like Sarah, it was one of the key recommendations. Social norm change. Because that is where we think issues of inequality, that's where they are sleeping. So if aggressively, but it may not be a role of Ministry of Gender, but our work would be having mechanisms of coordination, bringing identifying intention and deliberately contributors and stakeholders who can help us to demystify what we are calling social norm change. I think this is very key. Recently, we had a problem of the 400 girls who dropped out of school, 400,000 under the COVID arrangement. Struggled with means of education to come up with a re-entry program, second chance, which still gave us a recommendation. Now the issue is, who is out there to support the Ministry of Gender and the Ministry of Education to tailor this message that if it was a mistake that this young lady got impregnated, is it the end of the world that now you are saying you must be excommunicated? She had done something very evil. She can't be spoken to again. That could be a role of religious leaders to demystify that though fornication is bad, but somebody can be given a second chance to ensure that we can promote that for our girls to go back to school.
After all, the Bible says forgive 77 times 7. Okay, before I go to the audience, I want my sister Naku to tell us what strategies does UNAIDS have in place to address the specific challenges faced by out-of-school adolescents and youth in terms of HIV prevention and teenage pregnancy.
Thank you, moderator. As I mentioned earlier, UNAIDS is a secretariat for 11 UN agencies, so I will speak relating to what the broader UN is looking at, but also more with a drive from UNAIDS angle. I think one is Education Plus. Last year, with the leadership of the First Lady, we launched Education Plus. We are driving a campaign to intensively mobilize resources so that initiative is taken to another step where we see more money invested in education, whether formally or informally. We know as the UN, we have UNAIDS inclusive of that joint team. We have the UN youth program that has just been developed. It's going to be anchored in the Ministry of Gender. It will be launched on 18th during the International Youth Day. And the intent is specifically to tap more into the out-of-school, while Education Plus concentrates more on those in school But we also know for the previous 3 years with the leadership of Ministry of Gender, you are leading on running the Spotlight initiative. More financing has come up for other 3 years. And I think this time the Spotlight is moving away from general women and because it was tapping into women and girls. Now the call, it should concentrate on adolescent girls and young women. And issues to do with school have been slightly integrated. The more advanced part is more on economic empowerment. But as the UN, specifically in UNAIDS, we are utilizing the literal resources we still have, even with what our co-sponsors have, to concentrate more on economic empowerment ventures. Because ideally, even if you encourage people to take ARVs, but the stomachs are empty, they will not take the ARVs. Then you will see what we are seeing nowadays. ARVs used to breed chicken, ARVs. They don't do it because they don't want, but they are looking for alternative means of survival. And then they misuse the existing resource. So economic empowerment is one of our major drives now. As we said earlier, if you're to address inequalities, you have to address some of the predisposing causes and education. Poverty, gender-based violence, they are some of the major predisposing causes. We have been concentrating more with the King of Uganda for male engagement. You will soon hear us in Busoga with the Kyabazinga, specifically to address issues of teenage pregnancy in that particular region. And we believe we'll be in again as broader UN agencies. I think we are around 5. And we hope we can convene in there under our CEDA grant, the partnership that we have with Sweden. But we also know that our co-sponsors, specifically UNICEF and UNFPA, they are running a teenage pregnancy campaign, which was initially hosted by the most powerful 3 ladies in this country. But then as we discussed further, we realized it needs to move away from the powerful 3 ladies to go to the actual holders of the challenges and see if it's ministries, but with the communities, the young people themselves being in the lead. We've never given up on working with religious leaders. We are trying to initiate partnerships mainly with private sector. Like we know that some radio stations are owned by religious leaders. How can we use them and utilize them for messaging? We've already reached out to not Kingdom Family group of media, and we know Father Sheldon is one of those key members in that. So we are trying to see how do we utilize the influencers in religion and culture to change the perspectives and the minds of the people. But our major drive now is more on integration, because you realize resources have declined. We no longer have a swimming pool in HIV where we used to swim. The pool has now become, I don't know whether it's now a pond, because many people are in that pond fighting one another. The big fish eats the small one, then the small one survives, the other doesn't survive. So that is what is happening. Before it was a big pool. You mention HIV, you dive in, you swim and get out of the pool. Now, whoever goes into HIV mainstream alone, you go to that pond, the big fish can eat you up, or you can fight and also get out of the pond. But it's rare. The big fish has, in most cases, the big ones eat you up. So now we are calling upon integration to say integrate. When we are talking about HIV, let's talk about teenage pregnancy. Talking about HIV, let's talk about gender-based violence. If we are talking about HIV, let us not forget the non-communicable diseases that accompany people living with HIV later as they age with HIV. When we are talking about HIV, let us not stop talking about the convenient laws, the favorable laws that should enable us end AIDS, but also other health-related burdens. So integration is our way to go so that communities can survive in that pond and they are not swallowed by the big fish. Thank you.
Thank you very much. Thank you very much, the panel. Oh, I recognize my boss, the chairman of the National Youth Council of Uganda, Mr. Jacobo Eyeru. Thank you for joining us. They were asking me, where are the other youth? That one is a representative of all of them. Thank you for being here. Now, I want to turn to this side, and I want to request one of my colleagues to come and get one of the mic. We want the involvement of everybody. We are talking about inclusiveness. And so we cannot talk about inclusiveness without involve the people. Can I start with the chairperson of the HIV/AIDS committee in Parliament? Can I have the mic here? Your take on the discussion. We have listened in. What's our take?
Thank you very much, moderator. As the chair of the committee that handles HIV matters in Parliament, I am humbled to have all this big team, and I'm humbled that I'm part of this dialogue, because to end HIV, it needs all of us. We cannot do it alone as legislators, but having all of you as part of this team gives me hope that we will get there with all the challenges around. My one concern is on sexuality education. And this goes to you, Mr. Commissioner, and Ministry of Gender, together with the Ministry of Education. Without us giving the young people correct information on sexuality education, it may be very difficult for us to address the issues of HIV and AIDS and the issue of teenage pregnancies. All these come at the end of it all. We are battling it out. Now we have abandoned it as a policy. We want to merge it and come out with one inclusive policy where sexuality education is just going to be one of the objectives in there. My take on this is I hope we don't lose it. I hope, Mr. Commissioner, that we don't lose the aspect of sexuality education. We need it both to the people in, our young people in education, those who are still in school, and also those who are out there. And also giving correct information to the public. What entails in the sexuality education. People out there think that sexuality education, we are going out to teach people how to have sex. That is the perception. Actually, even us in the house, when you speak about sexuality education, you'll even get your colleagues shutting you down. People need to understand when we speak about sexuality education, what do we want to achieve? What is our target? That is my one area. The second area is on the issue of the convenient laws. I know our young daughter spoke about the laws that are hindering us to achieve our target in ending HIV by 2030. We are working together with Uganda Law Commission, Uganda Human Rights Commission, and they have come up with about 8 clauses that are almost, they are concluding their final stage to bring back this act or this law back to Parliament. We look at it as committees that are related. We have brought many committees on board. Health is part of it, human rights, equal opportunities, legal, all these committees we are working together. We want to sit down and see how we can address the gaps that are in the HIV Act to make sure that we get a law that is all inclusive and that can help us to get there. I think together with my boss, Honorable Dr. Ayume, I'm privileged that he's my boss on the Health Committee. but I'm also his boss on the HIV committee. So both of us sit on the others committee, and it's giving us quite a good atmosphere to work together. We've been talking here with him on how we can involve UNAIDS, Uganda AIDS Commission, Ministry of Gender, to update us on the current status, and also give us all those demographic reports on how HIV is as of now and the dangers it exposes us as a country, and what we can do as Parliament together with you to end this vice. So we were discussing here, and I think we will get back to you and see how you and us can work together to achieve this goal. I want to thank you.
Thank you. The boss of my boss, Dr. Ayume. Now speak to us. They kept on referring to you. Could you kindly speak to us about the subject of discussion? Thank you.
Thank you, my boss, Honorable Sarah. Thank you very much. I have listened in, and it's objectively alarming, but I think we're on the right trajectory. I think as a doctor who did my training when HIV was a no-go area with a lot of stigma, and I think now we are seeing complacent. It's very rare in public now to see somebody with herpes zoster. But in the 90s, it was quite visible. You enter a taxi and everybody walks out. And like Madame Naku said, Dr. Naku said, Professor Naku, the pill burden, issues of the pill burden was like 18 drugs, and now you have one tablet. So I think it's been a good trajectory, and I think the future is bright. However, 2030 is about 7 years away. In war, there's what they call the final push, when you want to overrun the stronghold. And I would really want this meeting to tell us, what is the final push? What do we have to do right? How do you have to guide us on the political side that this is a strategy? Because we cannot run away from politics, the politicians, because that's where the slicing is done. What we do as Parliament is legislation. I think the HIV/AIDS Fund has been hanging there for some time. Sarah has been running all over the place. But again, if we are to operationalize it, then we have to go and we have to go and amend the Public Finance Management Act. It's a vicious cycle. We have to go. It's not only about operationalizing the fund, but we have to go and touch and make amendments elsewhere. One of our runaway points is we are alive to the fact that donors have expressed interest in scaling down their support. And the government made commitments, and which I think in this budget that we have just passed, the only enhancements to NMS for drugs was 70 billion. 50 billion was for ARVs, because that's government's commitment. As donors scale back, we are saying we bite in with 50 billion. And the other 20 billion was for the newly promoted health center 3s and created health center 3s. So I think there's a commitment on the side of government, and as a committee, we shall keep on trying to meet the side of the bargain. Last week, we were in Komamboga Health Center 3. As a committee, we were moving around KCCA primary health care facilities in Kampala. And it was quite alarming. I was there with Honorable Mitali Sarah. And of 5,000 tests, there were 104 positive, newly registered positive. And for us, that was a huge alarm bell. The majority of these were between 20 to 24 years old. this is just one, this is in Equator, one station, that's Komamboga. So if I can extrapolate Kisenyi Health Center 4, Kiswa Health Center 4, and so many other places. So we actually have to go back to the drawing board and ask ourselves, what are the drivers of these infections? That's also what I want to hear in this meeting. And as I conclude, the UFIA report was released, I think, last year. I would really want Uganda AIDS Commission, UNAIDS, to present this report to an assembly of members of parliament from the Health Committee and the Committee on HIV/AIDS. It's a bulky report. I'm not certain that we have that time to go through. Personally, I do. I know what's in the report. But I'm saying if you can organize a true day and domesticate it for members who are not from a medical perspective to internalize, and that also includes the Uganda demographic health survey report. I think it should be coming out this month. But if you can do that, would be more than happy for us to get to know the indicators that you're talking about. Last but not least, let us also try and align. I've been hearing what are the community solutions, and that should be our direction. The new kid on the block is the parish development model. That is the Mugole. If you want anything to go through and you're talking to the president, you have to come in. You have to come in through that angle. If you don't, you will not get his attention. How do we align some of these strategies and some of these interventions to the PDM? And I'm happy to say that the Ministry of Health released their community health strategy this year, early this year. So some of the things we're talking about, understand the strategy and align so that we don't start reinventing the wheel. Thank you very much.
Honorable Dr. Charles, before you give away the mic, how do you see us strategizing to have some resources for HIV prevention through the ministry responsible for community development? And two, new reconsidered position about youth-friendly corners at health centers, whether 2 or 3 or 4.
Well, I think it's important that all our interventions have to speak to the current situation. The demographics at the youth are now the majority, so we have to align all our, like the adolescent reproductive health and so forth. All those interventions have to speak to now the youth. So yes, we need to have the youth-friendly corners, and not only in health centers, but even in these universities and hostels. You know, a youth really has to go to the clinic and is able to check for STIs, for HIV, because some of them, there may be that stigma of going to, you're living, are you in Mbale and you're going to Mbale Regional Referral Hospital just to check why you have, if you have genital herpes and all that. We can also employ this within the universities, because we have to keep on tracking where are we having high infection rates. Even for, in Komamboga, one of the issues the midwives are telling us is that how do you tap into somebody who is in the market from Monday to Monday, because that's where they are living. So can't we also take some of the services for testing and screening to markets? We are building these modern markets. Have we ever thought that there has to be a health corner and so forth? So I think it's it's beyond health facilities, but where people make their income from as well. Can I answer your question? Thank you.
Thank you, Dr. Honorable Charles. Can I go to the back? Somebody help me move the mic very fast. We want to redeem time. Choose anybody of your choice.
Thank you very much. I am Dr. Setabi Michael, today representing Buganda Kingdom through the Ministry of the Youth.
And Dr. Setem, if you have a specific question going to somebody, you can say this is going to so and so.
Exactly, but I would want to start with a comment.
No problem.
Okay, thank you. Now, for us to engage the youth in the non-academic or formal sector, we need to use structures that are in the informal organization. For example, in the Buganda Kingdom, we have youth leadership from county to village level of over 198,000. These are youth leaders. The messages we want to give the youth should resonate with the people they know, the people they live with in the community. We are failing to reduce the burden because the people we go to, we take the messages, they don't understand us as they understand the other young man he plays football with, if he's empowered to deliver that message to the peers. So I would encourage government, like the development partners UNAIDS has done with us, to work with our structures that are well established to help reach the youth down in the villages. We also have programs like of the Nabageka Development Foundation of Echisakate. Initially, most people thought it was for the Baganda or the people in Buganda. But our current statistics show that we have more than 40% of the people involved in this program that are non-Baganda. That means there is a training that we are giving people that gives them a cultural understanding and keeps them aligned to prevent chances of getting these infections. So what the ministries can do, they can use it as a pilot, and we go to other kingdoms, because I'll tell you, most of our people, our youth, still believe in the power of culture. So if we use it as a pilot, ask them how did NDF do it, and spread it to other kingdoms, you'll find that many youth, especially the non-educated, will get this information easier and better. And finally, about the kind of message, we as a country have empowered the girl child through the affirmative action. But we have forgotten the man or the boy child who is going to live with an empowered woman. The level of violence you are seeing is not because the women are not empowered, but the people they are living with do not know how to deal with an empowered woman. Now, the message we pass on that has always not resonated with the youth, and that's why our numbers are increasing, is because we give them what we think they understand. I was talking to youth in one of the universities, and a young lady told me, as we know, when I take paracetamol before intercourse, I'll prevent HIV, a university student. Now, what do you expect that one who has not gone to school to believe? So as we try to tailor our messages, we need to give them a message they understand. And now for us, we are saying, tell them as it is. The parents, you're masking, you're hiding this information, assuming that the child or the young one will understand. They never understand. So we need to tell them as it is, because still at 13, they're getting pregnant. Thank you.
Thank you, Doctor. Doctor, before you give her the mic, what are some of 2 or 3 cultural practices in Uganda that would prevent teenage pregnancy?
Now, using, for example, our Chisakate program and the youth policy program. For the Chisakate, we have messages that are tailored within each age group bracket. Now, those messages show these girls what do they expect to do, at what age, and at what time. And now we have brought on people who are in the same age group to explain these very dynamics to them. If a young girl knows that at this age, I'm not supposed to engage with men, these are the repercussions. They will try to run away from it. Now, for our youth policy, it gives us different age groups and different targets of what information they should receive. To prevent people who are not meant to receive certain information from absorbing it. So that helps different groups prevent themselves from what? Getting HIV and early teenage pregnancies. Thank you.
Thank you, Doctor. Dr. Joyce, I'll be getting to you. You'll be making a comment about what would be the role of a Choto in, preventing some of the things we are talking about. But I'll be getting back to you when you put up your hand. But be on notes. Can I get the next?
Thank you so much.
Yes.
I'm Kenneth Mwehonge from HEPS Uganda, and mine builds to the Honorable I missed her name, the first speaker, on the national health policy. I know the cabinet moved to have one policy per ministry, and in particular around engaging adolescents, it takes care of sexuality education. However, it talks of collaborating with the Ministry of Education and Ministry of Gender. For education, the implementation is very clear through the national curriculum. But to Ministry of Gender, it's still elusive on implementation on reaching adolescents out of school. And I've heard my previous speaker speak of initiatives like Ekisakate. I think we need to take advantage now that it is still draft for us, especially the Ministry of Gender, to lead this, to guide on what strategies, implementation strategies will reach out of school children, especially adolescent girls, through initiatives like Ekisakate, that's a good classic example, and many others. But we need to tap into that draft and ensure that we have clear implementation strategies for the out of school. Thank you.
Thank you very much. Nampija Prosi is my name. I'm a Principal Urban Officer, Ministry of Local Government. In the Local Governments Act, we have services that central government is responsible for, and they majorly deal with standardization or setting national standards. Then we have those devolved to local governments. And one of them for the districts is related to medical and health services, which include being responsible for hospitals other than referrals, control communicable diseases, including HIV, AIDS, leprosy, and tuberculosis, health education, PHC, maternity, and child care stroke welfare. And for any successful program or intervention, for any program to be successful, it should be integrated in the local government agenda, because we are closest or nearest to the people, and we are better placed to provide locally acceptable solutions. And for local governments to prioritize an intervention, which the Katikkiro of Uganda calls okusosowaza. For any local government to okusosowaza any intervention, it should be included in our assessment manual. We have two types of assessments. We have the one the Ministry of Local Government is responsible for, the Local Government Inspection Manual. We also, that one can be done quarterly. We also have the one of OPM, which is done annually. It's called the Local Government Management Service Delivery Assessment. And because of that, I believe that the local governments should be looked into at the implementation stage, and even during this stage. We also have well-streamlined structures provided for under the decentralization policy up to village level. These administrative units or councils have three mandates majorly. Let me look at the village. The village council is legislative, judicial, and administrative. It is fully composed with the membership clearly spelled out. And among them is the secretary responsible for information, education, and mobilization. We need to tap into that structure. Let us not leave the local administrative units to only recommend youths to join armed forces and also certifying deaths for onward submission to NIRA. We need to engage them even for such kind of intervention. We also need to look at this, I should call a wrong approach, for lack of a better word, where we are more curative than preventive. When you look at the primary health care grant sent to health centers, it is inadequate. So you find that many health centers will, let's say, extend this education in regard to HIV, AIDS, and others to those patients or caretakers that have gone to the health facilities. Yet they are supposed to look out for them. It is an outrage.
Thank you. Can you lastly comment about the efficiency of the local government councils in handling issues of the community, including teenage pregnancy?
The efficiency
and effectiveness.
The efficiency and effectiveness. These local councils, they are supposed to have a register of all the people residing in the village. They have a village council. It is supposed to sit at least once a month to address issues that are due to them. And when they address them and fail to resolve them, they refer them to the next level, that is the parish. From the parish onward to the sub-county, and even some issues from the village level can go to the area magistrate to handle.
In your view, on a score of 0 to 10, how are local councils doing?
8 out of 10.
Maybe on land issues. Okay. Haji?
Yes.
Let me hear from a religious leader.
Yes, thank you, the moderator and the panelists.
Is that mic on?
Yeah, it's on. Okay. That's my voice. We've heard you very well, the presentations. Now from the religious perspective, I would like to go directly to our recommendation. One of the issues that we've had is about information, which is lacking within the community about HIV/AIDS. We have our institutions, health. We've been partnering with the Ministry of Health, we've been partnering with the Ministry of Gender and many other ministries to see how best we support our communities through our institutions. We have health facilities, we've been giving services. We have schools, we've been educating the country. We have also our media houses. I've heard you talking about the media houses. I would like to see you also in our media houses as Uganda Muslim Supreme Council. They are there. Kindly don't fear them. You come to us. We shall allocate you programs through our media houses so that we have Bilal FM, we have Bilal TV, we have Masaba in Bugisu, we have Ribat in Yumbe.
We have dedicated airtime to issues of teenage pregnancy, the corporate social responsibility of the Muslim faith or the Christian faith.
Yeah, it can be, but we need to partner and see how best, because also the radio is not, you charge us. So we have to see how best we can balance the two. Yes. Then lastly is about the issue of the information. Can we partner with you, mostly these organizations, that we can use our structures, both in Christian faith and Muslim faith, because we have structures. As Uganda Muslim Supreme Council, we have over 15,000 mosques in the whole country. What if we have these imams and we give them the information, we educate them about what is happening, and this is the imam that can stand before 1,000 and talk about HIV/AIDS. I think